시청자 여러분, 안녕하십니까? TVK에서 매달 세 번째 수요일 저녁 7시에 현대의학 특집을 담당하게 된 UCLA 신경내과 조 교수이며 또한 신경내과 전문의인 전희택입니다. 오늘은 특별히 UCLA에서 감염과 수련을 마치시고 다년간 웨스트힐과 노스리치 지역에서 전염병 전문의로 활약하시던 감염과 전문의 존 윌렌 박사님을 모시고 각종 전염병과 특히 에볼라 바이러스에 대한 말씀을 들어보겠습니다. Thank you very much coming over here, joining us.
Well, thank you for asking me.
So let me just get started. Do you think we are over with the Ebola virus epidemics in this country?
Well, I don't think that we can say that there will not be further cases of Ebola in this country. The thing about the Ebola virus, however, is it's really not a major problem for the United States. It still continues to be a major problem in West Africa, particularly in the country of Sierra Leone. But as far as the United States, we've had the only cases in this country have been people who have contracted the virus in West Africa, one individual and 3 healthcare workers.
As far as I remember, the Ebola virus began in 1970s in more or less Central Africa, a sub-Saharan desert like Congo and Sudan. And how it...
You are correct. It was 1976.
Toward the more Western Africa now.
Well, certainly that's where it is centralized now in Western Africa. Why it started there, I don't think anyone really can say. We know that the Ebola virus probably originates in primates, in monkeys, and there's a practice of eating monkey meat in Africa, which certainly leads to the spread of the virus or to transmission to humans. What we know is unique about this particular outbreak of Ebola, however, is the rapidity with which it spread and the number of cases. The prior epidemics of Ebola or outbreaks of Ebola that you alluded to generally limited themselves to a few hundred people because the virus rapidly, unfortunately, killed a lot of people, but therefore limited its spread. There wasn't any geographic migration. The difference is, because of the current political situation in Africa, especially in West Africa, the borders amongst these countries are very porous, allowing free movement across borders in these countries. And that's the real reason that the virus spread so rapidly to so many people. Even though it's limited to primarily 3 countries, the reason it did spread is because of the geographic and political situation in West Africa.
I see. Ebola virus is transmitted from monkeys and bats and so forth, but does it also transmitted human to human?
Well, yes, the primary mode of transmission is human to human. However, what you have to remember is it's only transmitted by those individuals who have symptoms of Ebola, which are primarily high fevers, nausea, vomiting, diarrhea, muscle aches, and it's transmitted by bodily fluids. It's not transmitted through the airborne route. So you cannot get Ebola virus by just being in the same room with somebody that you're not touching, or somebody coughing. You're not going to catch Ebola virus from somebody who has Ebola but has no symptoms. The time that people are the most highly contagious is what the healthcare workers who treat Ebola refer to it as wet cases and dry cases. The dry cases are those people who may have a fever and feel not well, but don't have nausea, vomiting, diarrhea, and sweating. Those are the wet cases, and those people are highly contagious through contact with those bodily fluids. The other way you can transmit Ebola is after death. There's a large amounts of Ebola virus present on the skin and in the sweat and in bodily fluids of someone who's died of Ebola. So in Africa, one of the burial practices is for the family to gather around the body and then everyone to come and embrace the body. This was prior to the epidemic. And that's certainly a very efficient way, unfortunately, of transmitting Ebola.
So what are the most common symptoms? Nausea, vomiting,
Well,
fever, right?
right.
And they have the Ebola virus disease also called hemorrhagic fever. So will they bleed internally? Or?
What you're referring to is what happens in the final stages of Ebola.
I see.
The people who recover primarily from Ebola virus, and remember, not everybody dies from Ebola. Right now, the current statistics in Africa are unfortunately, it's about 35% mortality. But the people who die from what is called Ebola hemorrhagic fever, and as you alluded to, profuse bleeding and failure of multiple organ systems is what leads to death. Mm-hmm. And that's precipitated also by, in Africa especially, by such massive fluid loss that the individual becomes dehydrated and then the various organ systems begin to shut down.
Okay, so what are the diagnostic procedures that is available for us?
Well, there's a what's called a PCR test, which is a blood test.
Right.
And early on, the viral load in people with Ebola is going to be low, so you're not going to pick it up. But the severity of the symptoms is directly correlated with the amount of virus in the blood. So the peak amount of virus in the blood is these so-called wet cases, or people who have Ebola hemorrhagic fever, or people who die of Ebola.
So polymerase is like DNA test,
right,
isn't it?
Right.
So you try to identify the DNA of the virus.
Right, right. It's not a culture method.
Right, by doing the blood test.
Correct.
Okay. Now, what is the other virus test like ELISA?
Well, there are antibody tests,
right,
but those tests are not very useful in actually making the diagnosis because, first of all, it takes longer to perform, mm-hmm, and they're not useful in following the patients. One of the things that's done, especially in the cases that were treated in the United States, is they do serial testing in order to monitor the progress of the disease. And as you begin to recover from Ebola, the viral load then comes down, and that's how they decide also when somebody is safe to be discharged and removed from isolation, is when the viral loads become undetectable. Then transmission is no longer possible.
What is the treatment in these people? I hear there is no specific treatment for the Ebola virus.
That's correct. There is no specific licensed treatment for Ebola virus. The hallmark of therapy for Ebola...
There are no antibiotics.
There are no antiviral agents available.
Right.
The story is that the primary treatment available currently is administration of intravenous fluids in order to reverse the massive fluid and electrolyte depletion. So it's administration of fluid and electrolytes, things like potassium and magnesium,
right,
calcium, and
because of nausea, vomitings, and diarrhea.
Exactly.
Okay.
Now, what's been used in some limited fashion, which has been in the press, are things like what's called ZMapp. Mm-hmm. Which is an antibody against the Ebola virus.
Okay.
Or taking a blood from someone who's recovered from Ebola and then transfusing that blood into because there's high titers of antibodies, mm-hmm, transfusing this. There are direct acting agents being studied.
Okay.
But they're not obviously available yet. There's also vaccines being studied. The vaccine looks in primates looks very promising, actually.
All right. So no specific treatment, but we have to do very careful fluid management,
right,
intravenous fluid, electrolyte management. Do they have any respiratory symptoms?
Well,
respiratory failure?
Well, ultimately what happens because of multi-organ failure, I don't want to get too technical here, but yes, what's called adult respiratory distress syndrome. It's not a direct infectious pneumonia, but yes, it's basically a failure of the respiratory system as well, just like failure of the kidneys.
Secondary complications.
Right.
So how do we prevent it? I mean, it's a preventive measure. It's very important.
Well, the way you prevent transmission
stop the spread of disease
is by monitoring people for development of fever. Certainly people who have been exposed to Ebola need to be monitored carefully over a 21-day period, because the incubation period of Ebola goes up to 21 days.
That's why we do quarantine
and those
for
people
21 days.
In Africa, they need to quarantine those people and monitor them. Now, not all of them are certainly, in fact, the majority aren't going to develop Ebola. But if you get people who have been exposed, then they do need to be quarantined and monitored. And the checking temperatures at the airport when people are leaving West Africa. If in regards to the United States, there's no direct flight, so they fly to Europe. They're monitored again in Europe, and then on arrival in the United States, they're monitored again.
So normally this disease was around every year in Africa.
Well,
the outbreak this year was extraordinarily large.
Yes.
What is the mortality so far?
Well, so far, like I said, is about 30. Earlier on, it was higher, but the most recent statistics tell us that the mortality is about 35%. There's been well over 15,000 cases and over 5,000 deaths. Now, having said that, those are the official statistics. Most experts on Ebola predict that those statistics, the official statistics, underestimate the extent of the problem because of the obvious difficulties in third world countries like Liberia and Sierra Leone in attempting to gather the proper statistics.
According to the latest newspaper report, there were total of over 4,000 mortalities this year.
Well, it's over that. It's over 5,000 actually.
Is that right?
The most recent numbers are about 5,300 in that range, and in the range of about 15,500.
So this year we have 4 or 5 times more mortalities than a perennial mortality of Ebola disease. 1,000, 1,500. Why this year is more prevalent and more severe? Even came to the United States.
Actually, in prior outbreaks, the mortality from Ebola has been 60 to 90%, actually. So in terms of prior outbreaks, the actual death rates are lower. However, the amount of number of cases, the prevalence and the extent is higher. And as I alluded to, the reason for that has to do with the geographic and political situation in West Africa.
And people travels more.
Well, that's right, and also that people travel more in the countries like Sudan, for example, where it previously occurred. People were not traveling across the border to other countries with Ebola. In this situation, that was not the case. These borders are porous. There's political unrest going on in these countries, which allows people to freely transport themselves across borders. And that's the primary reason why this particular outbreak has been so severe. I don't think there's evidence that we have strains that are any more virulent in this particular outbreak. It more has to do with factors on the ground.
Okay. So in America, so far, we only had one casualty.
That's correct.
Mr. Duncan.
Well, we did have a second casualty who was a physician, who was an American citizen, who was working in a hospital in West Africa, and he came back, I think, to Minneapolis.
So he died here?
He was treated in Nebraska. Actually, he was treated in the facility in Nebraska, and he died here.
Okay. All right. Before we go too far, let's talk about the another viral disease. Is West Nile virus still around here in this country?
It is, but interestingly enough, if you look at the statistics for West Nile, right now the number one state, if you will, for West Nile happens to be California.
Mm-hmm.
In this country,
why is that?
Well,
you know, mosquito. We don't have much mosquitoes.
Well, we do have mosquitoes, and you know, we have the weather that is warmer here than in
marshes
but for whatever reason, California, in this year at least, leads the nation. There have been close to 1,500 cases of West Nile this year in the United States. About 735 of those cases have been in California.
Okay.
And
what about the mortalities?
Well,
the mortality is not that high.
No, the mortality is not high. Is not that high. For example, in even in the last week in Los Angeles, in California, there have been 10 cases, 5 cases in LA County,
okay,
and 2 deaths.
2 deaths.
Yeah.
All
and
right.
So the case fatality rate for West Nile is not that high. It's higher in the elderly, the very young, and people with chronic illnesses or people who are immunosuppressed.
Immunosuppressed.
Those kind of people.
Right.
But the West Nile is sort of a pyramid. You can have asymptomatic infection all the way to a flu-like illness with no neurological manifestations, all the way up to full-blown meningoencephalitis or even a polio-like syndrome.
Right.
So with West Nile, it's a whole spectrum of disease.
West Nile's spread by mosquitoes.
It is
right?
spread by mosquitoes.
Just like other encephalitis.
And intermediate vector are birds, and that's one of the ways that public health officials become alerted to West Nile activity is when you start to see dead birds, because unlike what the virus does in people, with birds it's almost uniformly fatal. So if birds get West Nile, they die.
What are the viral diseases that could become an epidemic? What about that SARS, the severe respiratory, acute respiratory syndrome?
Right, and that was certainly, as you know, primarily a problem in Asia and Canada.
Right.
And that was back in around 2009.
Hong Kong.
Right. And that was a very, very severe illness that was highly transmissible by the airborne route, by the way, in hospitals even. And that, of course, created a huge problem back in 2009. Luckily, in the United States, we had it, but not to the extent that it was in Asia and then in Canada. There also was, more recently, within the past year or so, what was called MERS, Middle Eastern Respiratory Syndrome, which is actually a coronavirus, just like the SARS virus was. That was spread actually through camels to people. You know, in the Middle East, people eat camel meat apparently, and they obviously ride camels. So, and there were a couple of cases that got to the United States.
What are the treatments with the SARS and MERS?
All these are just supportive treatment. There's no antiviral agent that's effective against these things.
Diagnosis again by PCR?
Well, yes, and there's blood tests available for those too.
Okay. Now, recently there was a newspaper report that we have outbreak of that norovirus. What is norovirus?
Well, norovirus is primarily a food and waterborne or fecal oral transmitted virus, and it's primarily a gastrointestinal illness. Severe nausea, vomiting, and then diarrhea. It can produce fevers. It's fairly highly contagious because it's fecal oral, and it tends to peak in a few hours and last no more than 48 hours is the classic case of norovirus, the so-called 24-hour stomach flu, people call it, you know. And
because it can be transmitted easily human to human.
Right.
And a crowded living situation, like a cruise travel and
well, the cruise ship is sort of the classic description of it, or classic environment for a norovirus outbreak because of the, as you allude to, the closed conditions. There have been outbreaks in hospitals as well, nursing homes, hospitals, any situation where you have people, you know, in a closed more crowded situation.
Okay, so partially self-limited disease. So you again have no specific treatment.
That's right. It's a virus, and as I said, it usually
Right.
doesn't last longer than 24, 48 hours.
A lot of intravenous fluid and electrolyte management.
Yeah, some people don't even require
rest.
hospitalization. They just take some anti-motility agents and fluids, and they get better.
Okay, so what other epidemics, viral epidemics around? How about that H1N1? Is that
Well,
still
influenza is with us every year.
Okay.
And you know, people were worried about Ebola, but when I tell people, don't worry about Ebola, get a flu shot.
All right.
Because flu in this country kills almost 50,000 people a year.
So when we get the influenza vaccination, that covers H1N1.
It does.
As well as whatever is current.
That's right. It's usually two strains of influenza A, which H1N1 is an influenza A.
3 strains, okay.
And then two strains of that, and then 1 strain of influenza B. Now there is this year a new, what we call quadrivalent vaccine, which actually picks up a 3rd strain of influenza A.
Okay.
Whether or not that's necessary is debatable. In addition, for people over the age of 65, people over the age of 65 and people who are immunosuppressed, have chronic conditions, who are at risk for more severe disease, there is a vaccine that it contains a higher level of antigen, and that produces more protection because you get higher antibody titers with that vaccine.
Okay.
And for people who don't like needles, there now is available a needleless injection system. And then, of course, in people under the age of, between the age of 2 and 49, there's a lot. The influenza vaccine is a killed virus vaccine. So people who say, I got the flu from the vaccine, you can't do it. There's no live virus.
Right.
But there is a live attenuated, what we call it, in medical terms, attenuated, which means there's live virus, but it's weakened. It's weakened.
Right.
And that's available as a inhalation. It's called flu mist. And that's for people aged 2 to 40 to 50. It's not for the elderly.
So usual flu vaccination will prevent the most frequent viral epidemics. What about the...
and by the way, people who have egg allergies, they worry, as long as your egg allergy is only hives and not difficulty breathing, anaphylaxis, you can take the standard flu vaccine. There is a new, what we call a recombinant flu vaccine, which has no eggs at all exposure, and therefore if you have a history of very severe egg allergy, you can take that vaccine.
Good. Well, that's good news for the people with
egg
allergies.
So anybody who even has a severe egg allergy, there is now a flu vaccine available for them.
So let's talk about other vaccinations. We have pneumonia vaccination, right? That's always important because that even with the viral disease, people oftentimes die with the secondary infections and pneumonia.
Correct.
Those are pneumococcal pneumonia, so who should have a pneumonia vaccination?
Okay, I'll tell you that, and I'll tell you that there's new news in the field of pneumonia vaccination as well. First of all, who should have it? Certainly anyone over the age of 65 should have it.
Right.
Just like we talked earlier with the people who are at greater risk for influenza, those are the same people at risk with pneumococcus. Anyone with chronic heart disease, lung disease, diabetes, kidney disease.
Regardless of age.
Regardless of age. And anyone who's had their spleen removed as well, because you've had your
immunosuppression.
Right. those people are all candidates for pneumococcal vaccination.
But if you're over 65, you should have vaccination regardless, is it?
That's correct.
And the pneumonia vaccine is required only once in your life, is that correct?
Yes and no.
Oh.
Okay. First of all, like I said, there's news. There's a second pneumococcal vaccine. It's called Prevnar 13. Mm-hmm. The previous pneumococcal vaccine, which we call Pneumovax, is a polysaccharide vaccine which contains protection against 24 strains of pneumococcus. The Prevnar is a conjugated vaccine, and that vaccine contains 13. It contains all the strains that are in the polysaccharide except one. The difference is it produces a higher level of protection against those strains it does contain than the old vaccine.
I see.
So the recommendations are now anyone who's immunosuppressed, those same high-risk groups, and anybody over the age of 65 should receive both vaccines. Mm-hmm. So, for example, if you've never received any pneumococcal vaccine, you should get Prevnar first, and then 6 months to a year later, get Pneumovax, or the one that we have now, the 24, the polysaccharide vaccine. If you have previously received the Pneumovax, you have to wait greater than a year after that to get Prevnar. So if a year has gone by, then you can get Prevnar. Now, the recommendation, you asked only once. The recommendation for the polysaccharide vaccine is if you received that vaccine before the age of 65, you should repeat it every 5 years. That still stands.
Okay, every 5 years. All right. What other vaccinations are available? How about that shingles vaccination?
Okay. That's called Zostavax.
Zosta.
Okay, now Zostavax, this has actually recently been looked at by the experts. And what's recommended is that this is a shingles vaccine.
Right.
So,
how effective is it preventing the shingles?
Yeah, it's in the range of 60 to 70% effective. No vaccine is perfect, but it's recommended for anybody over the age of 60 because that's when the incidence of shingles in people who've previously had chickenpox begins to rise. Mm-hmm. It's also true that the efficacy of this vaccine is not permanent. Probably is no more than about 5 years.
5 years.
So it's not recommended you get a second shot. It's recommended that you don't get a shot till after 60 because in that period after 60 is the peak incidence of getting shingles. Mm-hmm. So it's recommended that anybody over the age of 60 is a candidate for the shingles vaccine.
Shingles vaccination. Okay. Thank you very much, John. Nice.
Thank you for having me.
To you. 시청자 여러분, 많은 도움이 되셨으리라 믿겠습니다. 자세한 것은 주치의와 상의해 주시기 바라며 오늘은 여기서 그치고 다음 시간에 찾아뵙겠습니다. 감사합니다.